case was recently done and illustrates multiple important teaching points. And it was just a routine right-sided implant. And of course, we're using the table in a perpendicular position. We have the Worley sheath positioned at the SVC RA junction, and we're advancing a hand-shaped multi-purpose catheter over a glide wire. And then the CS is engaged by withdrawing the MP2 with counterclockwise torque. A puff of contrast identifies the CS. We then advance a glide wire. And it's important to note that we're using a guide, a 6 French guide, not a diagnostic catheter, because a guide lumen is large enough to accept 2 wires or to do the anchor balloon technique. So, and you can also inject contrast when there's a wire, which you can't do if it's a diagnostic catheter. So here we have the 6 French multi-purpose in the coronary sinus, and it was difficult to advance. And so we're injecting contrast to see if there's any obvious target veins. And you can see that there's a big, large posterolateral branch. So in order to increase support in an attempt to cannulate the coronary sinus, an Amplatz wire was advanced beside the glide wire, again 2 wires, and then to make that even more powerful, we took the glide wire out and advanced a second short taper Amplatz wire. And now we're advancing, and we're trying to advance the Worley sheath over this combination, but it just wouldn't go. So rather than continuing to fight it, we left the tip of the sheath at the CS os, and we loaded the vertebral vein selector inside the renal 5 French LVI and advanced that over one of the 2 Amplatz wires that was in the coronary sinus. So that's what we're doing here. And we're able to get the vein selector deep into the coronary sinus. And once we achieve that, now we're advancing the 5 French renal LVI over the Amplatz, over the vein selector again, which is supported by the Amplatz wire. So we're able to get the Amplatz, we're able to get the renal LVI and vein selector deep in the branch, or deep in the coronary sinus. And so we removed the Amplatz wire, number 1, that was inside the vein selector, and placed it with an angioplasty wire. Of course, here's a second Amplatz wire, which remains in position in the coronary sinus to stabilize the situation. We then advanced an angioplasty wire through the vein selector, and it went down the side branch. And we initially thought that this was the side branch we had seen originally, the nice big large anterolateral branch, but the vein selector didn't go very easily, and so we contrast was injected by the vein selector to assess the wire location. And with this, it became apparent that we are not in the vein that we thought. So then we repositioned the vein selector further distal in the coronary sinus. And again, all of this is being done with great skill by the young attending and the fellow using the table. So we're able to reposition the vein selector into the upper, more distal branch, and then advance the vein selector into the branch. And we're injecting a little contrast to confirm that, yes, we're in the branch we wanted to be in. And then we put a second wire down and then advance the vein selector over 2 wires. If you look carefully, you'll notice that the 2 wires are actually separated here. And the vein selector stopped advancing, And so it became apparent that both wires weren't down the same branch. So to get a better sense of what was going on, we moved to the RAO projection. You can see clearly now that there are two separate branches beyond this point. So how do you know which wire to advance over? Again, the ability to inject contrast through the vein selector allows us to define which is the larger of the two branches and which goes less apical. So we decided to choose this branch as the larger branch, and we added a third wire. So the third angioplasty wire went here. So there's two wires here and one wire there. And then we repositioned the third wire from the side branch into the branch of interest. So now we have three wires going down. And again, the reason to put multiple wires is evident by the tortuosity of getting into the coronary sinus. So you really need the wire support. So once we're in this position, we have the vein selector deep in the target vein, and then we'll advance the subselector over the vein selector. And then once we get into that situation, we leave three wires in place and remove the vein selector. Then we remove all but one of the two wires, and then we advance the pacing lead over the one wire that's in the target vein. And remember, there's not enough room for a buddy wire, so you have to take all the wires out except for the wire that you're advancing the lead over. So we got the lead right to there, and it wasn't quite deep enough. So one of the things that I think we all forget is that if you put a soft stylet to the tip of the lead, you can often advance the lead further than you can advance it by pushing it over the wire. So here we've done is we've advanced the stylet to the tip of the lead, and with that we're able to get the lead a little deeper into the branch. So with that, then we remove the sheath. Usually you don't take the sheath out till the end, but in this case the sheath seemed to be destabilizing things. So we're peeling the sheath away, and now we're slicing the renal LVI away. And again, we're maintaining that one Amplatz wire, and now we're removing the Amplatz wire. And you'll notice as we do this that the Amplatz wire wants to hook the lead, and if the stylet wasn't all the way to the tip, it might have pulled the lead out. So you want to make sure the stylet is in there when you're removing the Amplatz wire. So finally, we remove the stylet, and you want to do that very quickly. It's sort of like starting a lawnmower. You want to pull it out quickly so it doesn't have a chance to destabilize the lead. And as always, you want to check the amount of slack that you have in the LAO projection. You want to see the wire, the pacing lead, go to out of the coronary sinus, across the bottom of the right atrium, over the lateral wall of the right atrium, and then up the SVC. And so this was a tour de force of a combination of skill on the part of the implanting physicians, not me, and as well as having the proper table and having the equipment necessary. And so this is a list of the teaching points. And the lumen of a guide catheter is large enough for two wires, and you can inject contrast with the wires in place to determine the location of the catheter. By comparison, a diagnostic catheter will take only one wire and cannot be injected effectively with the wire in place. It is essential to use a short taper J-tip Amplatz wire in the coronary sinus to get support needed. Currently, only Cook and now Merit Medical make a short taper wire with a J-tip. In some cases, it is better to leave the Worley sheath at the os of the CS rather than continuing trying to advance. Every time we tried to get the Worley sheath deeper into the coronary sinus, it destabilized the situation, so we just left it at the os. Using the vein selector to inject contrast in the target vein is essential to determine which vein you're in and to select the optimal side branches. So if you just poke a wire around up there, you never really know where you're going. When the renal LVI is deep in the vein, the lead can often be advanced further if the wire is replaced with a stylet to give it extra push. In the CS and in target branches, more wires provide greater support and stability. Once again, you can put two 035 wires fit through a 6-French guide, which is the catheter we use to locate the CS. You can put 4.014 angioplasty wires will fit through the vein selector. In this case, we actually use 3. And having the vein selector deep in the target vein supported by multiple wires makes it possible to advance the renal LVI deep into the branch, which effectively guarantees lead delivery. I hope you find this useful. I thought it was a very good case for several teaching points as illustrated here.